Good evening and welcome back to our live IVF webinar. As always, I am your host, Caroline, and I am very happy to be back after a summer break. As always, also, please let me know that you can hear me loud and clear so we can begin with our IVF webinar. And so once again, hello to all of you. Hello to Dr. Laura. It's good to have you back with us as we have another topic to discuss. And today, the topic is how likely is my treatment to succeed when the difficulty lies in the male factor. So, as always, we have a very special guest, Dr. Laura García de Miguel, and she's the medical director at Clínica Tambre, which is located in Madrid, in Spain. And of course, she will start off with her presentation. After that, as always, it will be time for your questions. So let me just simply remind you that the questions you need to put in the chat section so that Dr. Laura can answer them for you just after the presentation. And I'm very happy and excited to be back here with all of you. As you know, we will have more and more of those events coming up. Today is our very first one after the summer break. And I am definitely excited to find out what Dr. Garcia has prepared for us. So I guess for now it is all. Just remember, this is being recorded, so you will have a chance to rewatch this again. And well, Dr. Laura, are you ready to begin?
Thank you very much. So today we will talk about how likely is my treatment to succeed when the difficulty lies in the male factor. And as Caroline said, I'm Dr. Garcia, I'm the medical director, and I'm very happy to introduce this topic to you. And of course, feel free to ask me whatever you need and whatever question you have. So what will we cover during our presentation? Our first topic is about steps at Clínica Tambre. The second is the basic diagnostic of female factor analysis. The third is complementary semen test. The fourth is treatments for male factor. The fifth is azoospermia, and six are our conclusions. So what are your first steps at Clínica Tambre? First, you will have the possibility to have an appointment with one of our fertility experts. Then you will have a full anamnesis and the birth diagnostic test. And of course, you will have an appointment with our urologist if necessary in your case. Before the consultation with the expert, it's recommended to do the sperm test, and freezing is recommended. We'll select the best treatment depending on your history and also depending on the sperm results. We will indicate specific tests in the sperm if necessary. Of course, we will introduce and explain all the treatments that are possible to improve the male factor, such as antioxidants, curcuma, whatever. And also, we will have the urology consultation if necessary. In our andrology lab, we have the possibility to do the seminogram, also to do the fragmentation comet fertility test. The chromosperm, that's a genetic test in the spermatozoa. The fertile chip, which is a magnificent technique to improve the results for that man having abnormal comet results. And also we have our semen bank. In the urologist consultation, we will take care of severe cases of male factor. We will have the possibility to do testicular scan to exclude pathology that could cause that problems. And also we can organize in our clinic the testicular biopsy if necessary. It's always recommended to do karyotype for everybody having problems of fertility, but it's always obligatory if there is a male factor. It consists in a blood test, and we will exclude translocations and other genetics problems that could cause the male factor. Here you have in the right photograph the normal image of a karyotype. of a man. So normal man for karyotype should be 46XY. If there is any abnormality in the karyotype, we will indicate PGS, okay, if the karyotype is abnormal. So it means that we will do a biopsy of your embryos to confirm what are the normal embryos in terms of chromosomes, and we will exclude the abnormal ones. Other tests that can be indicated for the male factor is FSH, LH, testosterone hormone test to know if there is a secretory or obstructory problem. We can also indicate Y chromosome microdeletion, also a blood test. So Y chromosome microdeletion is a family of genetic disorders caused by missing genes in the Y chromosome. Many men with ICM exhibit no symptoms and lead normal lives. However, ICM is also known to be present in a significant number of men with reduced fertility. Also, we can indicate to do cystic fibrosis. So most men with cystic fibrosis, around 98%, are infertile because of an absence of the sperm canal, known as congenital bilateral absence of the vas deferens. Let's move to the basic diagnostic of the male factor, which is the spermiogram. In the spermiogram that we always recommend to have the sample in the clinic, in a specific room for you, we will consider general aspects evaluation, such as pH, color, viscosity. We will also study concentration and motility analysis, and very important also morphology tests. Regarding concentration and motility, it's very, very important, these two parameters regarding the spermiogram, because it's important to know that the normality is to have at least 15 million per milliliter of spermatozoa. So with this type of microsome, we will study the concentration that men have, in particular in this spermiogram. Of course, there is always a variability. There is no man having same parameters in different samples, in different spermiograms, but there is always a tendency. And it's very, very important to understand that concentration is one of the main parameters to understand fertility in a man. Regarding motility, always the biologist, which is an expert in the male factor in our clinic, will study what type of abnormality these men can have. So we need to study the motility type A, which is the most progressive mobility. Also the percentage of spermatozoa that move also but not that fast, which is mobility B. Then we have spermatozoa moving but not having a very important trajectory, so they are moving but not moving to another place, which is mobility C, and D are spermatozoa that are not moving at all. Regarding morphology, I explain you that the normality is to have at least 4% of normal, 100% normal spermatozoa. But of course, I have a lot of patients telling me, oh, I only have a 5% of normal spermatozoa. This is a catastrophe. This is, you know, a real problem. So this is not a problem if you have 4% of normal spermatozoa, because we have millions and millions in the sample. So the majority of them are abnormal, having head defects, achromless, which means acrosomeless, which means that this spermatozoa has not the chromosome part, mid-piece defects in the neck, or tail defects in the spermatozoa. Here we have the resume of the normal parameters. Regarding volume, it's 1.5 milliliters at least. Regarding total sperm count, it's at least 39 million, and concentration minimum 15 million milliliters. Regarding mobility, if we consider the whole mobility, it's 40%, but if we focus on progressive motility, so spermatozoa A and B, it needs to be at least 32%. Regarding vitality, it's 58% at least, and sperm morphology, as I said before, 4%, pH more than 7.2, and peroxidase positive leukocytes less than 1 million per milliliter. It is very, very important in the spermogram to confirm the number of sperm recovery during swim-up and sperm survival after 24 hours. So it will give you it will give us a number, and regarding this, we will consider the specific treatment for your case. So if we have more than 6 million per milliliter, even having problems such as mobility, we can indicate IUI. If we have 3 to 6 million per milliliter, if we go directly for in vitro fertilization, we can do the classic in vitro fertilization. But by contrast, if there is less than 3 million spermatozoa per milliliter, we need to go directly to ICSI, which is the intracytoplasmatic sperm injection. If the results of the spermogram are altered, it must be repeated. And of course, the following aspects need to be evaluated because could interfere in the results. So the time for the sample collection, we always recommend to our patients to have the sample in our clinic, because the soonest the sample enters in the laboratory, the best for considering and studying the results. The loss of some fraction also needs to be reported to the biologist. The sexual abstinence is also very important to consider, because if we have more than 3 days of sexual abstinence, it could interfere in the problems. But of course, if we have a long sexual abstinence, such as 2 weeks, of course, definitely we will have problems. If also is necessary to ask for the ejaculation frequency of that patient, the last fever period, because if we have a long time of fever, the 3 months before having that sample, it could interfere. The intake of medicines in that previous time of 3 months, and also the current occupation. Here we have some terminologies of problems that we can find in the semen. So we have aspermia, for instance, which is the complete lack of semen. We also have asthenozoospermia, which is the less than 32% of sperm with progressive motility, or less than 40% of total mobile sperm. Azoospermia, which means absence total of sperm cells in semen. Hypospermia, which is less than 1.5 milliliters in the semen. Oligozoospermia, which is less than 15 million sperm per milliliter. Necrozoospermia, which is more than 58% of dead spermatozoa. Teratozoospermia, more than 4% of morphologically abnormal spermatozoa in that sample. And leukocytospermia, more than 1 million leukocytes per milliliter, which usually indicates a genitourinary infection. Regarding the complementary semen analysis, we can do in our clinic comet fertility, the fragmentation analysis, the chromosperm, and the semen and urine culture. Let's focus right now on comet fertility. So comet fertility is a test that allows us to evaluate the percentage of fragmented sperm in an ejaculate. But what is sperm fragmentation, and when is this test indicated? There is 2 types of fragmentations that we need to consider, is the simple strand fragmentation and the double strand fragmentation. For the simple strand fragmentation, this really needs to be studied when we have failed IVF cycles and an impaired correct fertilization. The double strand fragmentation is indicated when we have recurrent miscarriages in that couple, a failed IVF cycle, and a poor embryo quality. Comet fertility can also be studied in a first cycle without previous failures. And when we do recommend to study that, so when we have low concentration and low motility, mainly when we have less than 10 or 5 million per milliliter, and also when motility is less than 25%, when there is a long infertility of many years, and when the man reports that he's smoker or has a high intake of alcohol, or also takes more than 2 cups of coffee or tea per day. If the simple strand DNA fragmentation is altered, it is normally treated with antioxidants for 3 months, and usually our patients improved a lot. And it can be, with coenzyme Q10, zinc, magnesium, so whatever antioxidant multivitamin that you can buy. And when double-strand DNA fragmentation is altered, fertile chip can be used to select sperm in our laboratory of IVF when the eggs are in our laboratory. But the double-strand abnormality that recommends chip fertile, it's not always possible. So the results of double-strand, if it's less than 60%, it's normal. If it is between 60 and 80% of fragmentation, we do recommend chip fertile, and we will have good results with this technique, with this filter. And if we have more than 80% of abnormality of fragmentation, we need to decrease that fragmentation, and we do recommend curcuma piperina for 3 months. You can take with specific vitamins, or you can take with the normal spice, but it's recommended with vitamins. And if after 3 months it is still very high, then we should consider sperm donation or genetic screening of the embryos, because with more than 80% of fragmentation, the chip fertile cannot work and have good results. And it's very important to remember that with chip fertile, it's always recommended to use a fresh sample. Right now, let's talk about semen and urine culture. So we do recommend when leucospermia is present, so more than 6 leukocytes per 40 fields. When there is a severe astenozoospermia, so less than 20% of motility, sperm agglutination, or hypospermia, which means less than 1.5 milliliter per of volume. So it's very frequent to have infections in the genitourinary tract in the oligoastenoteratozoospermia problem. And it's always necessary to have 3 samples. So the first urine, the second part of the urine, and the semen in the last part. It's very important to identify if the infection is the cause of that oligoastenoteratozoospermia, because we have lots of patients when we identify the problem is the infection, after treatment they improved a lot. It's always recommended to use antibiotics for 3 weeks and repeat the test and confirm that the infection is no longer there. Sometimes there are repeated prostatitis, so it means that perhaps we can have a first round of antibiotics not achieved to have the normal sample, and we need to do more and more rounds of antibiotics. And sometimes we need to do different antibiotics and freezing sperm after washing, because sometimes in many patients it's very difficult to achieve sperm without infection in that type of problems. There is another test, which is the chromosperm, and this test allows us to evaluate the chromosomal content of the sperm in an ejaculate. It is a rapid and effective way of detecting general chromosomal alterations in the sperm that could affect the success rate of treatment. So even we have the karyotype in the blood test normal, if there is a problem in the sperm, in the male factor, we will indicate the chromosperm in the sperm. If the sperm is very, very low quality and we have had different failures, or if there is azoospermia, we can always use our sperm donor bank. And of course, when there is a severe case, there is the option of using that. We have extensive selection process of the donor, and we also have the technology of PhenoMatch to select the best donor for you. Clínica Tambre has the oldest sperm bank in Madrid, and it's one of the oldest in Spain. Its founder, Dr. Caballero, began his work more than 40 years ago, adapting to advances in assisted reproductive technology. What are the treatments that we can do in male factor? We have IUI for not important cases, not important severe abnormalities, IVF, ICSI IVF, and progenetic screening. So IUI, it will be indicated only if very good prognostic. So the sperm needs to have a recovery of more than 6 million per milliliter. It's indicated in young women with a short infertility time, and we will recommend no more than 3 to 6 cycles. So I remember you that IUI will stimulate a little bit the ovaries of the woman, and then when the follicle or follicles are ready, we will ask the sperm of the partner, and we will concentrate and introduce in the uterus. That sperm needs to wash and needs to run in the tube and found the egg and fertilize correctly, and that embryo will implant in the uterus directly. But of course, this technique, it's not a technique that has a very good chance of ongoing pregnancy, mainly in the male factor. So it will only be indicated if we have very good prognostic. If we have, regarding the sperm, at least 3 to 6 million per milliliter, we can do classic IVF, which means that once the eggs are obtained in the egg retrieval, we will live in our media culture with a drop of sperm, and the best spermatozoa will fertilize naturally the egg. It could be 100% IVF, which means that all the eggs will be with classic IVF, or it can be 50% IVF and 50% ICSI, if we are not sure that this patient in particular can have a good prognostic with total IVF. We know that this natural process compared to ICSI has better neonatal outcome than ICSI. ICSI is the main treatment that we will recommend for male factor, and it is an artificial selection of the spermatozoa. We will have an 80% more or less fertilization rate, and of course it's obligatory if we have oligoactinoteratozoospermia in the sperm. Progenetic screening also will be done after the in vitro process if we have abnormal karyotype in the man or also in the woman, if we have abnormal chromosperm test, or if COMET is very high, the double brain. And as I explained before, it is the biopsy of the embryo. We will study some cells of the external part of the embryo, and we will confirm which of the embryos are having normal chromosomes and which are abnormal and needs to be excluded from embryo transfers. Regarding azoospermia, it could be because of secretory problems or obstructive problems. So secretory means that there is no production of spermatozoa, and if it is obstructive, it means that there is an obstruction in the seminal conducts. So we could go to the testes and do a testicular biopsy. For azoospermia and severe oligosteinoteratospermia cases, it's very, very important to consider the parameters in the spermiogram. So we need to consider volume, pH, and biochemistry. We go to the right part and we will have a maltase less than 20. It is an obstruction of the epididymis. And then we need to do testicular biopsy and we need to do ICSI. By contrast, if we have hypospermia, so a low volume, a low pH less than 7, and a low fructose, it is reminding us there is an agenesis of ducts or vesicles. So we need to do the study of cystic fibrosis. If it is negative, so if we don't have a man with cystic fibrosis, we can do testicular biopsy with ICSI. By contrast, if there is the problem of cystic fibrosis, then we need to do testicular biopsy and also genetic screening of the embryos. In the part in the middle, if we have low volume with leucospermia and phosphate and citric acid, it reminds us there is an infection. We need to do semen and urine culture and recommend treatments with antibiotics. And if by contrast the semen and urine culture is negative, we should do testicular biopsy. If volume, pH, and biochemistry, everything is normal, then we need to do Y chromosome microdeletion. And if the problem is that, we should do testicular biopsy and also the counseling for that and the genetic screening. And if we don't have that problem, we need to do FSH and LH hormones. In the right, if they are low, we need to remember that we are in front of a hypogonadotropic hypogonadism, and we need to use gonadotropins injections to try to make the function of the testicular come back to normality and see if we achieve sperm. And by contrast, if the FSH and LH is normal or high, then we should go to the testicular biopsy and consider doing the ICSI process. The Y microdeletion chromosome, as I said before, it's a blood test, and Y chromosome deletions are not always linked to the azoospermia. So we have 3 phenotypes with clinical relevance different. So microdeletion AZFA, it's a 5% of total, and we have the Sertoli syndrome problem, and we cannot have spermatozoa with this kind of problem. AZB, it's a spermatogenetic crypto or azoospermia block, so again we cannot have spermatozoa. And AZFC, 60% of total, in this problem in particular we can have severe oligo to azoospermia, but we can try to work with the sperm of that man. So depending on the type of microdeletion, if it is the AZFA or B, it is necessary to go directly to bank sperm, so donor sperm. And if it is the deletion, the microdeletion of C, if there is spermatozoa in the sperm, then we can do ICSI procedure, doing the genetic counseling and explaining the couple that this problem could be transmitted to sons, and sons could have also infertility due to that issue. As our conclusions, it is very important to study in deep every case. So counseling of treatments and pregnancy rates are extremely important to inform to that couple in particular. And only in azoospermia or very severe oligosteinoteratospermia, sperm bank if necessary. We are a clinic with a long history with male factor disorders, and we have a very high success rates. So thank you very much for your attention, and everything is going to be fine.
Excellent. Thank you so much, Dr. Laura, once again for a very thorough presentation, for explaining all the factors and, of course, how we can treat them as well. And as always, it is time for our Q&A session. We do have a few questions ready. And as always, just let me remind everyone that if you would like to ask anything at all, you can go ahead and type this in the chat section. And we will start with the first question that we received. And this is a very common question, of course. Which supplements are best for sperm quality?
So it really depends on each problem. By as I said before, if the problem is fragmentation, single strain, then it's recommended antioxidants. And by contrast, if the problem is with a double fragmentation, the recommendation is curcuma. But if you want to do the mix of antioxidants and curcuma, it's absolutely fine. So whatever antioxidants such as coenzyme Q10 and magnesium, zinc, whatever will improve. There are usually multivitamins that you can buy directly in the pharmacy that are vitamins specific for male factor.
Okay, thank you so much for providing the details once again on the supplements. And let me go to the next question that we have right here. My partner has 2 healthy children from previous relationship, but now has male factor, 1% normal morphology. Would he need karyotype testing? Children at 9 and 10 years old. Also, does poor morphology mean poor DNA fragmentation? And thank you for that question.
So yes, thanks for that question. In my recommendation is that if he has previous children, it's not necessary karyotype. Only if after or before that children he had miscarriages. And regarding the poor morphology and poor DNA fragmentation, if there is a very low poor morphology, it could be also abnormal in fragmentation. But I have lots of patients having abnormal morphology, and then when I do the fragmentation, everything is absolutely fine. So it's not necessarily linked.
Excellent. Thank you once more for explaining that to us. And the next question is also up here. Can my embryos with PGS be wrong? Many negative transfers and 2 biochemicals. My husband has a severe male factor. We did only fish for the sperm in the PGS. What can I do? Thank you.
So thank you very much for your question. Yes, if we have different failures, it's always necessary to remember that the embryos, because of the male factor or because of the X, so could be abnormal. So yes, we have this need to do the PGS, and also I would recommend to start doing implantation failure if you have had different blastocyst transfers of good morphology. So not only doing pre-genetic screening, but also doing the implantation failure study with the window of implantation, hysteroscopy, coagulation disorders, immunological problems, etc.
All right. Thank you once again for your question and your help with this as well. And next question is right here. Do you do micro-TESA surgery at your clinic?
So right now we do TISA. We do the TISA because our urologist consider has best outcome with that. So we don't have the microtesis surgery.
Okay, thank you for the clarification once again. And let's have a look. What is your opinion regarding overheating testicles, wrong style of life, and radiation exposure? Keep phone in a pocket close to testicle.
So thank you very much for your question. Yes, lifestyle is something very important. We do have patients such as, for instance, drivers that are seated lots of, long time. And that could be, a problem for the sperm function. But of course, we are all in a world that it's really crazy having phones and many radiation close to us. So we know this is not positive for the sperm, but by contrast, we cannot only consider this is the problem for the male factor. So again, we need to improve our lifestyle, no smoking, having a very good diet with a lot of fruit, vegetables, fish, and also consider having vitamins and these types of species, like for instance curcuma. But yes, we cannot only focus with the radiation problems.
Okay, thank you once more for this as well. And let's have a look. The next question is, of course, ready right here. Do you think there is still little investigation into causes of male factor infertility by clinics?
So thank you very much for that intelligent question. Yes, I think we really focus a lot with the eggs and the women and the age, but by contrast, sometimes we don't spend enough time to study the male factor. So I completely agree with you.
All right, thank you so much once more for that question. And let me have a look. Of course, there are plenty more coming up. So here's the next one. Does a low testosterone correlate to a low sperm count? If so, what treatment would you recommend?
So it's not only the low testosterone that really is the cause of the sperm count. So we need to do all the tests that I recommend before, mainly FSH, LH, regarding the parameters in the spermogram, and see if finally it is because hormones are low, FSH, LH, and testosterone. Then treatments would be gonadotropins to improve the count of the sperm in case there is a very severe oligoacinoteratosospermia or azoospermia. By contrast, if there is more than 1 million milliliter, then it's not necessary to do that, and we just go directly with ICSI procedure.
All right, again, thank you so much for your question and, of course, your help with this. And let me go to the next question. I have normal volume and pH, but zero sperm in ejaculate. What could this indicate?
So again, with normal volume and pH, we need to do all the tests I said before: karyotype, Y microdeletions, the cystic fibrosis, and very important to talk with urologists to understand what is the problem and if we can go to the testicle, because it is a obstructory problem and we can retrieve spermatozoa from the testis or not.
All right, again, thank you so much for that. Let's have a look. There are like 2 questions left. So if you have any more, then go ahead and type those in. And the question is right here: had donor egg and partner sperm. ICSI was done. He had infection in his sperm, loads of round cells, had 2 miscarriages at 4 or 5 weeks. Could it be during ICSI that dodgy sperm was used? Have 2 embryos remaining. Would PGS be able to detect if there are any chromosomal issues?
So thank you for that question. Yes, it could be one of the problem if there is infection. Some of infections, for instance, ureaplasma, could really cause repetitive miscarriage. Okay. By contrast, there is a problem that your embryos are already frozen, and with frozen embryo, it's not really recommended pregenetic screening because it's an invasive procedure, and with frozen embryos, it does not really work very well. So you need to also do the miscarriages repeated tests to understand where is the problem. And if everything is absolutely clear and you don't have problems in the uterus, you don't have problems in your coagulation, in your immunity, then you need to talk with your clinics and understand if it is more convenient to do the transfer directly, or if by contrast they would recommend another round with more embryos, and to all the embryos do the genetic screening.
Once again, thank you so much for your question and, of course, your answer to that. And next question is also here. How many days of absence would you recommend prior to giving a sperm sample? I've read 1 day is the best, but been told 4 days.
So the idea right now in the latest studies is around 3 days. So I would say 2-3 days is the best, between 2 and 4. 1 day it's a really very short time. So usually concentration could be decreased. So at least 2 days of abstinence and no more than 4 days.
All right, again, excellent. Thank you so much for clarifying that. And there's another question from the same patient. So does abstaining for 1 day rather than 4 days reduce the DNA fragmentation?
Thank you. Very good question. Yes, we consider fragmentation could be decreased when there is a shorter time of abstinence. For instance, in the chip fertile, sometimes we ask 2 samples in the same day. So yes, with a short abstinence, it could be reduced.
All right, again, thank you so much for explaining that to us. And again, there are 2 questions left, so let me go to this one. So can sperm count be improved with free-way exercises?
So there is not evidence that sperm count could be improved with exercises. So of course, fragmentation and all the quality inside could be improved if we change our lifestyle, but not the sperm count.
All right, okay, thank you for that once more. And at least for now, it looks like this is our last question. But of course, if you have any left, you know what to do. And the question is here. I have low sperm count around 60,000. Everything else is good. Is ICSI our best option? 3 boys from prior marriage. Youngest is 7.
So thank you very much. Yes, absolutely. We can work with that sample, but it's really necessary to go directly to ICSI procedure. So I wouldn't recommend other treatments in your case. And also, it looks that you should have change in your sperm parameters. So perhaps it could be important to exclude any infection and do sperm and urine culture.
All right. Again, thank you so much for your question and, of course, your answer to that. I am waiting. Someone is typing, so I just want to make sure we have another question. So let's give it a minute. Let's wait and see. I guess there it is. Is it true that if a blastocyst reaches day 5, that means that nothing is wrong with sperm?
So thank you very much for that question. We do understand that the specific work of the sperm in the embryo starts from day 3, okay? But it does not mean that if there is a blastocyst, even of good morphology, reaching day 5, that everything is okay with the sperm, because it could be also abnormalities inside the sperm, such as abnormal fragmentation or chromosomes disorders that could interfere in the genetic charge of that embryo.
Okay. Thank you so much for explaining. And actually, there's another one here. So I've read that if an embryo arrested at day 3, it's due to sperm.
So 50% of embryos are not evolutive from day 3. But depending on each case, if all the embryos have good development till day 3, and then by contrast there is no embryo achieving day 5, yes, we need to study more in deep that sperm to exclude problems with fragmentation, for instance.
And once again, thank you so much for that. And let me have a look at the next question. How can necrospermia be treated? Is it curable if not severe?
So mainly for necrospermia, what we need to exclude is infections. If the cause is infection, it will be improved after antioxidants. By contrast, if it is not the cause, then there's nothing to do, only antioxidants. But of course, although it's not a good parameter, it's not a positive parameter, if concentration and mobility it's good and we do ICSI procedure, the results are going to be good.
All right. Once again, thank you so much for your question and, of course, your help with that. At least at the moment, there are no questions. But of course, if you have any left, this will be like a final call for your questions. If not, we will be slowly finishing for tonight. But of course, let's give it a minute just to make sure. In the meantime, let me remind you that, of course, if you would like to get some more thorough details, of course, from Dr. Laura and her team, you can also reach them, and I'm sure they will be more than happy to help you out. And of course, there are plenty of other possibilities like online consultations, etc. I will put a link right here for you. So if you would like to get in touch with Dr. Laura and her team directly, you can use this link. That way you will be able to ask even more and more questions. At least for now, I do not see any other questions. So I guess we will be finishing for today. So I would already like to thank you, Dr. Laura, for being with us once again. It's always a pleasure, and I'm very excited to let you know that, of course, this is not our first webinar with Dr. Laura, and definitely it's not our last. There are more of those coming up as well. Thank you. We already have a shout out right here. So I just want you to see it as always. And thank you so much for your for being with us tonight, and thank you for your questions. I'm sure it was very, very helpful for you. Dr. Laura, is there anything else you would like to add?
Thanks for your time, and thanks for sharing your cases with me and your questions.
Excellent. Thank you so much, of course, as well. And I just want to remind everyone that, of course, this has been recorded. Therefore, you will have a chance to watch this again. And of course, you can see in the chat section the link where you can see all the previous webinars with Dr. Laura, but also all other ones from June, etc. And I just want to let you know that you can find all of our previous webinars on my IVF Answers YouTube channel, but also if you follow us on our Facebook, you will be able to see all upcoming events. And just so you know, tomorrow at 8 p.m. UK time, we will be back here with Dr. Claudia Mika, and she has another topic to present. So I definitely hope to see you back here. And there are many, many more of those events coming up. So thank you so much for your questions. And of course, have a lovely and restful evening, Dr. Laura. Thank you so much once again.
Thanks
Happy to have you back here. It's always a pleasure. So till the next time, right?
Thank you very much, Caroline.
Thank you so much, everyone. Bye.